2021, the new year. And we are starting off the year with a bang. Our patient that we're going to be operating on this morning with a Deuk laser disc repair is for a herniated disc at C5-6. 2, 3, 4. So if you want to cover the name. Sean, you can come in and take a look at this MRI and show our viewers the herniation at C5-6. Our patient is asleep. They are intubated, completely out of it. We have the best anesthesiologist in the world. Dr. Santiago is here. He drove up from South Florida, drove through all the bedlam to be here today to operate with us. And he's also going to be here tomorrow and Thursday. He'll be doing the anesthesia on Thursday. We have 2 big cases. We have anterior cervical discectomy and fusion, 3 levels, C4, 5, 5, 6, 6, 7. And we have a 4-level transforaminal lumbar interbody fusion, lumbar fusion basically, with osteotomies and deformity correction. Can you see the MRI? Sean?
Yes.
Oh, hi. Well, are you looking at the MRI? Go to the laptop computer. And let me know when you're there. And can we put that view up on the screen? Up there so I can see what Sean's looking at?
We are zoomed into it.
All right, I'm going to swing over there. And you all see the herniated disc right here? Yep, that's what we're going after right there. And that's number 2, bone, number 3, 4, 5, 6. Okay? So we're doing a 5-6 disc herniation. The patient has pain from his neck down into his arm on the right side. So we're always go the opposite of the worst arm symptoms. Our table's a little higher than normal. Is the floor all the way to the ground? Yes, sir. Okay, and that's our picture right there? That's really good, actually. All right, and we're relaxed completely?
Check it out, let me know.
Yeah, so our patient is intubated under general anesthesia, plus they have muscle relaxation. It's very important for this procedure that the patient is completely relaxed. We call it chemically paralyzed. And what that means is we use a chemical, a drug, through the veins to make the patient's skeletal muscles not respond to any stimulus. Normally, if you push on a muscle, there's a reflex activity. So it's a little bit tight, but I don't feel any muscle contraction. So it may just be his soft tissues are a little bit scarred up from something that happened in life. Who knows? All right, so shot. 2, 3, 4, 5, 6. So I'm a little bit above the disc. And rather than sliding, I'd rather reposition. It's better that you reposition. Now I can feel the carotid artery. I can feel the trachea and esophagus shut. And I've moved them to the side. Let's get an AP real quick. So I need to check the positioning on the lateral view, which is what we just did, and I need to check it on the AP view. Go. So I'm a little bit too close to my side. I need to go more towards the midline. Shot. All right, that's better. Let's go back to a lateral view, please. And let's make it quick, because my fingers are hurting. Our patient is in slight extension. We have a shoulder bump under his shoulder. Perfect. Come down just a little. 2, 3, 4, 5, 6. Everybody agree? Shot. All right, AP quick. So I want to make sure I'm between the longest colli muscles, aka I'm in the middle of the spine. There is no dead center. It's actually about a centimeter wide. All right, so I'm a little bit off to my side. I want to reposition and go a little bit more towards the center. So I'm going to lift up. We're going to slide over, and I'm going to come back down and shot. That's probably as good as we're going to get it. Lateral, quickly. Shot. All right. So I should be in the disc shot. Okay, give me an AP and a coker. Whew. This is hard on the fingers, I will admit. So any surgeons interested in doing this, be prepared. It hurts. It hurts briefly. All right, looking good. I don't think we have a true AP. Maybe we can straighten the neck out a little bit. Dr. Santiago, would that be possible? Yeah. You can see how it rotates off to the side. Maybe you can adjust the fluoro. Adjust the fluoro. It's not quite centered. You need to rotate it somehow, one way or the other. Rotate it more. Shot. It's closer to the center. Yes. I think we're okay there. But you're also flipped. You need to flip the image. All right. That is kind of centered there. Can't really see the spinous process. It looks like it's rotated still. Is there any way you can get me a better centered view? I think you're still a little bit overexposed. It's hard to see the spinous processes. Try rotating it a little bit more and see what happens. Other way. Shot. That's better. And let's see, one more shot. No, I think I should move a little bit more over. Take that. I'm going to take this out for a second. And I'm going to reposition. I'm going to need a lateral view. And then an AP. Just hold the head in traction. Don't let it move when I push. And try to extend it just a little bit. It's perfect where it is now. If we could just keep it there. All right, 2, 3, 4, 5, 6 is good. Give me an AP now. Quickly. Shot. All right, that's better. Lateral. Hitting something like bone. Quickly. Two, 3, 4, 5, 6. Shot. Shot. Give me an AP. Quickly. That looks pretty good. Coker. Shot. All right, I like that better than I like the other one. And let's go lateral. So far we have a drop of blood, just one drop for the surgery. Shot. 2, 3, 4, 5, 6. Everyone in agreement? Perfect. Take. All right, so we're inside the 5-6 disc, and we're going to do what's called a discogram. That's where we're going to inject some dye. That way we can see the tear in the back of the disc where the herniation came out. All herniated discs must have a tear. There is no exception. That's what we've discovered, me doing this for 25 years. How's our blood pressure?
Right now it jumped to 115.
Okay.
Bringing it down.
All right.
Yes, that is it.
So far we have our needle in the C5-6 disc. I've verified anterior and lateral projections and they look good. Shot? All right, so there's our discogram. You can see the dye leaking out the back of the disc. AP? So, you got that, Sean? 2, 3, 4.
Yep, we see it.
Yeah, it's actually, you can see the tear on both sides. You can see the dye. It looks like a mustache or a smile. Right where the corners of the smile are, that's where the dye is coming out the back of the disc on both sides and getting onto the nerve root. You can actually see the blush of the dye on the nerve root, especially on the left side of your screen, which would be the right side of the patient. So the opposite of the side of the needle. Go back to a lateral, please. So basically, this patient has a big tear in the back of his disc, and that tear in the annulus fibrosus, it's a tear in the annulus fibrosus, or the outer ring of the disc. The disc has two parts. It has a central nucleus pulposus. Now look at the lateral view, how you have a double shadow on the vertebral body. It means you're not a true lateral. So you need to get a true lateral. You can see the herniations in the foramen. They're like two boobs back there. Oh. And that's actually the dye outlining the disc herniation. That's a little better. Keep going. So the patient has, that's better. So the patient has a little bit of scoliosis in the cervical thoracic region, which is, you know, causing us to not have a true lateral unless we rotate the fluoro. But I think we're fine now. We can see the spinal needle going in through the front of the spine. You can count the vertebrae. There's number 2. There's a disc space. Number 3. There's a disc space. Number 4. There's a disc space. Number 5. Disc space where the needle is, and 6. So we're at the C5-6. That's the level we're supposed to be doing. Everybody in agreement? All right, we're ready to get started with the surgery. So obviously we've already started the surgery, but the real part of the surgery, we've just done our discogram. I'm going to take the, how's our blood pressure?
109. Coming down.
Perfect. I'm taking out the needle because we're done with it. Now, some people ask me, is the Deuk laser disc repair percutaneous? The answer is no. It is not a percutaneous discectomy. Percutaneous procedures are those done through a needle. We're not doing the surgery through a needle. We use the needle to get to where we need to go. We use the needle to do the discogram, but that's it. We're done with the needle. So a percutaneous procedure would be finished right now. We're about to start the real surgery. Now he's got a little vein here that we clearly invaded when we went in, and that's fine. I'm not worried about superficial veins. Needle down. We're going to make our incision in the skin. We're on the left side of the neck. I'm going to make an incision right where the guide wire penetrates the skin. And it's just a 4 millimeter incision. 4 millimeters. The smallest incision in the world for spine surgery. And only the Deuk laser disc repair has this incision. All other surgeries involve a much bigger incision. If you watch on Thursday, 2 days from now, in the afternoon, we'll be doing an anterior cervical discectomy and fusion. That's a standard surgical incision for a fusion in the neck. And you'll see just how big that incision is. All right, now we're going to advance this dilator. Okay, and the squiggly black thing is the Raytec right here. That's this little sponge I'm using. It's not actually inside the patient, it's out on the skin. So we're going to advance the dilator down. Shot. I'm going to keep an eye on the guide wire. I don't want the guide wire moving with the dilator. If the dilator traps the guide wire, shot, and moves the guide wire down, it'll go into the spinal cord. That would be bad. So I'm going to pull the guide wire back a little bit, shot. Okay. So the guide wire is still in the disc. The dilator is traveling along the guide wire. And I can feel the front of the spine right now. When I first published this surgery and how to do it in 2012, the neurosurgeons that reviewed my paper thought I was crazy. They said, this is so dangerous. What are you doing? You can't see what you're doing. And I said, are you kidding me? You're neurosurgeons. There's nothing you do in the operating room that isn't dangerous. And they're saying what I do is dangerous, right? They're nuts. You're talking about spreading the brain and clipping an aneurysm or taking parts of the brain out. That's not dangerous? Of course it is. They're just jealous because they didn't think of it themselves. The fact of the matter is that in medicine you have all kinds of people. You have those that are very happy to fix patients the best way possible, and you have many people who are jealous that the other doctor is better than them at doing something. Thank you, Luis. So they peer-reviewed it. They gave it hell, but they ended up publishing it because they couldn't deny the results. The results are scientific and fact. You can't deny results. All right, let's get an AP Coker. So I'm happy with the lateral view. The tip of the dilator is sitting at the front of the spine at C5-6. You can see there's a little bit of almost subluxation, but not really. It's weird. The C5 vertebral body is just bigger front to back than the C6. All right, so you can see the dilator is up against the anterior longitudinal ligament. The spinous process could be centered a little bit better. Let's try to do that. I'm going to get rid of the Raytech for a minute so that you can see without the Raytech there. Let's try to rotate it a little bit. Sean? All right, that's a little worse. Go the other way. You see how there's some scoliosis at the level I'm treating? You got a spinous process on one side, and then the other side it's the other way. So it's twisted a little bit here at C5-6. So we're actually going to be doing a disc repair for a herniated disc at a segment that has probably about at least 15 degrees of scoliosis, maybe 14, 12, somewhere in there. But we're not going to fix the scoliosis. All right, lateral view. So I'm happy with where the tip of my dilator is on the AP view. We're going to go in to the disc now with the dilator. And remember, we're not going to do anything to the front part of this disc. We're not taking it out. We're not damaging it. We're merely passing through. And we're passing through by spreading. We're going to spread the fibers of the anterior longitudinal ligament. We're going to spread them apart with the dilator. The dilator has not a sharp tip, but a pointy tip. And you can see how it trapped the guide wire and pushed it forward, or backwards, I should say. Forward with respect to the direction of the dilator, but backwards with respect to the direction of the spine. So I pulled the guide wire back, shot, and now I'm inside the disc with the dilator, and now I'm going to head to the opposite side, shot, because really we're going to fix both tears on both sides. I can do that with the cervical spine, but I need to make sure that I get the right side of the disc mostly. So I'm going to go across the disc, shot, to the back of the disc, shot. And that's where we're going to see this herniation, shot. Yep, right back there at the tip of the dilator. All right, folks, for those of you who have never seen this surgery done, it's pretty incredible. Take a look here, Sean. Show our audience. Blue towel. So this is Deuk Spine Institute here in Florida is the only place in the world you'll ever find this surgery done at this time in 2021. We've been doing it now 15 years here. And the problem is it's extremely technical to do it, and the equipment is very expensive, and nobody else really has it, and so they don't do it. It's a seemingly scary approach for a surgeon who's never done this before. And it is. It was scary for me the first 50 of these I did. But now I'm up over 1,200 of these endoscopic surgeries on the neck, the thoracic, and the lower back. And I'm very comfortable with the anatomy, the approach. We've had 0 complications to date. So I'm going to tell you all a little secret. You want to talk about trust. In medicine, there's a few things that are taboo. One of them is operating on your family member. This is my father who I'm operating on. So that's trust. He trusts me, and I trust the technique. I trust the surgery. I trust all my staff standing here. I trust Dr. Santiago. That's the kind of trust that we have amongst each other for this surgery. If this surgery wasn't available through me to do on him, he would have a fusion done, just like everyone else around the world has fusions. You don't need a fusion anymore. We can fix the herniated disc without fusion. There's no need for metal and screws and fusing bones together anymore. As a matter of fact, it may surprise you that I'm operating on my father-in-law here, but the truth is I've operated on many of my family members over the years. They all come here for surgery. Why do you think they come here? They come here because they don't want to go anywhere else. They know this is the very best care in the world they can get. All right, so we're going to proceed, but I want you to see something. The entire surgery is done through this little tube right here. This is called a tubular retractor, and this happens to be the smallest tubular retractor that's ever made for spine surgery. It's only 4 millimeters one side to the other. So the incision is only 4 millimeters because that's all you need to get the tubular retractor in. So the tubular retractor goes over the dilator, and I like to twist it as I go down to get any of the soft tissues like little veins that maybe stick into the wall. I don't want them tearing as I go in. I want them like releasing so I don't cause any bleeding. But you can see the whole surgery is going to be done through this little cut right here. And there's no hematoma in the neck. It's nice and supple. There's no blood clot under there. So with fusion surgery, you got to worry about blood clots after surgery. And I actually had one blood clot in one patient my entire career of 25 years for an ACDF. I've done over 1,000 ACDFs in my career. Lateral shot. I had one patient with a blood clot. Now, as I do this, I've got to watch the dilator, right? We don't want the dilator moving into the spine beyond the disc border and into the spinal canal, because that's where the spinal cord is. If I'm not careful, then I could paralyze him, because the top of the dilator will go right into the spinal cord and paralyze him. So I am going very slow, very careful, and once I get past the annulus and into the nucleus, it goes easier. There's less resistance and less grabbing. But you can see the dilator is going, the tubular retractor end is going over the dilator. Don't try this at home, kids. All right, we're just about there. Shot. And I'm just looking as I'm doing this. I want to make sure it's going perfect. And I want to get the end of this tube down at the back of the disc. That's the key. I think that's good. I may try to move the dilator in just a little bit more, mallet, and I'll need that back. Shot. So the dilator tip has moved back a little bit. Shot. So I'm pushing it forward. Shot. And give me that impactor. And then I'm going to advance the outer tubular retractor once again. We're at C5-6, the most common disc to herniate, the most common disc to have symptoms. Shot. Perfect. One more. Shot. That's perfect right there. I love it. All right. So we have not removed the disc. All we're doing here is passing through the disc to the back where the herniation is. And then I'm going to take the herniation out using a laser and pituitary rongeur. Let's show our audience what we've got here. We're pulling the fluoro machine out. The fluoro machine was used to make sure that we did the right disc, which we did, 2, 3, 4, 5, 6. The fluoro machine is also used to navigate the instruments to the back of the spine, to the back of the disc, which is what we just finished doing. So we use the fluoro machine for two things. The first is called localization, and the second is for navigation. And that's pretty standard in spine surgery. I'm not the first surgeon to do that. That's a lot of surgeons use X-rays or MRIs or CT scans for localization and navigation. So there's nothing unique or special about that. What's special is this procedure is done without removing the disc, only repairing the annular tear and removing the herniation itself. We leave the natural disc there, and because of that, the patient doesn't need a fusion, and they don't need artificial disc. Okay? The other option would be a foraminotomy, and that's where the surgeon goes in the back of the spine, drills a hole in your spine, removing the bone, and then can get to the disc. Beautiful, thank you. The surgeon drills a hole in the back of the spine and tries to get to the disc by going around the nerve root. It's crazy. Why would you want to drill a hole in your spine? Right where your facet joint is, by the way. My pedal is here. We're on 20. Are we on 20? All right, so there's a laser. There's our first piece of herniation, up and out. There's more pieces of herniation there. Remember, we're right at the base of the herniation. We're sitting just underneath it, and these are all fragments of herniation right here that are coming out. Okay, and the blue is the degenerated nucleus pulposus that's actually part of the herniation. The white stringy stuff is annulus fibrosus. So this is all herniated disc right here. I'm zapping away the blue stuff. Okay? Now what's amazing is once I get some of this herniated disc removed, like right there, you're going to start seeing the anatomy, the normal anatomy of this segment. And what I mean by that is you're going to see the C5 end plate, you're going to see the C6 end plate. Remember, we're going to see the C5 inferior end plate, and we're going to see the C6 superior end plate, because this is the C5-6 disc. So that's what you're going to see. We're going to see, sometimes you see a tear through the posterior longitudinal ligament. You'll see the actual spinal cord itself. We've seen that before. We prefer not to see that, but you know what? It doesn't matter. If that's what happens, that's what happens. We don't control the original injury that we're here for. That's the patient, okay? And if they have a subligamentous herniation, then you won't see the spinal cord. If they have a through and through, look at the herniation right there. You see that? There it is. It just popped out. You all see that come out? That's called a reverse herniation. We coined it here at Deuk Spine. We're the first in the world to coin it because we're the first in the world to see it. And basically, you have to do endoscopic surgery to see a reverse herniation. And there's nobody doing endoscopic surgery except for a few surgeons in the world. And most of them are just doing lumbar when they do it. And we're doing cervical, thoracic, and lumbar now in the year 2021. Last year, please don't hit my thumb, last year in 2020 was the first year we ever did thoracic. And it was a huge success. Woo! Look at that. That's a big herniation right there. All right, I need the grabber. I got to pull this thing out. I'm going to try to get it with the grabber. I'm not always able to. That I got it, at least part of it. And the reason you're not able to grab it out a lot of times is because it's scarred in there with inflammation and scar tissue. Yeah, herniated discs are inflammatory. They actually, the nuclear pulposus, once it gets into the annulus fibrosus, gets wedged in there. It creates a inflammatory response by the body within the annulus fibrosus. All right, so I got part of it, but I didn't get it all. There's a big piece right there. I'm going to try to grab it again. So I just couldn't get my grabber around it. I got a little bit of it out. If I can get this out, though, that would be wonderful. There it is. All right, let's get a light on real quick and a blue towel.
Yes, sir.
Sean, you want to take a look at this thing?
We can see it.
All right, where's a good spot? Right here? Look at
Yes.
that, okay? Look at that piece of herniation right there. We just grabbed it out with our little grabber. Our little grabber, you see that? I grabbed it and I pulled it out. So that's going to go to the pathologist, and just to make sure it's a herniated disc, which I already know it is, but that's standard operating procedure.
We have a question.
Sure.
One of viewers would like to know, would you ever use morselized graft in a fusion without the cage?
Would I ever use morselized graft in a fusion without the cage? Okay, great question. The answer is 99.9% no, I would never do that. except when I couldn't fit a cage in. So there are some discs that are so collapsed. These are all herniations, by the way, coming out. There are some discs that are so collapsed when I'm doing a fusion that I cannot get a cage in. So the smallest cage, for example, look at that herniation right there, folks. I'm going to grab that one out too. The smallest cage made for the lumbar spine is an 8 millimeter tall cage, 8 millimeter. And if your disc space, well, there's another herniation about as big as the other one. We don't need to see it. You guys have already seen it. But you get the idea. It's the same thing. It's the same size. We're going to keep pulling these things out till they're all gone. Now this is removing the herniated nucleus pulposus. But I'm also repairing the annular tear at the same time. Okay? Here's another herniation right there. And you're starting to make out the end plates. There's an end plate right there. That's the C6 end plate. And that's at 9 o'clock. So to answer your question, let me get the grabber again. The smallest cage made in the lumbar spine is 8 millimeters. If you go smaller than 8 millimeter, then the cage is not strong enough structurally, unless it's metal. But a peak cage, which is what I use, they're not strong enough structurally to support the weight of the spine. They'll just crush and crack. And you don't want a cage that cracks, because then the little pieces can pop out into the foramen and hit the nerve root and cause leg pain afterwards. So the smallest, shortest cage I've ever put in the lumbar is 8. I need the laser on. And if the disc space is, say, a 4 millimeter disc space, you're not going to get an 8 millimeter cage in there. So in that case, I would just use the graft only. Does that make sense? So normally I would never not put a cage. I don't believe in doing spinal fusions without cages. Cages are too important. They provide a lot of stability, and they share what's called the load, which is the weight of the patient through the spine. They share the load. They're called load sharing. God, this thing is huge. This is a big herniation. So, yeah, this is a complete blowout. That's why there's so much deformity, scoliosis. But nonetheless, we're going to fix this patient's symptoms by just doing this Deuk laser disc repair without fusing. I feel confident. This is all herniated, damaged disc. Let me get the grabber. So 85% of a patient's weight goes through the disc. 85% goes through the disc. 15% goes through the posterior elements, which are your facet joints. So think about that for a moment. 85% goes through the disc. So if you don't put something in the disc to, like a column to support that weight, what do you think's going to happen? Well, of course, the bones are just going to grind on each other after surgery. And so just putting bone graft doesn't work. But sometimes, like I said, there's no way to put a cage in. In the cervical spine, I've never not put a cage. I've always been able to put a cage in the inner body space. And you want that. Cages are important. Look at all those pieces of herniation. Cages are important because they allow the surgeon to, if they do it properly, to restore alignment of the spine, okay? And what I mean by that is particularly sagittal alignment and even coronal alignment. What I mean by that is simply that when a disc blows out, which is why you would do a fusion usually, when a disc blows out, the spine collapses. So it's like losing a tire on a car. Your car is going to sink down on that side where the tire blew out. You understand? And so to put the car back into the normal, normal height on that side, you have to reinflate the tire. And when the disc blows out, the spine literally collapses at that segment. And when it does, it shifts the alignment from a curve backwards to a curve forward. We call that kyphosis. So it's very important to put the alignment back to where it's supposed to be. Otherwise, the patient's going to have two problems. Number one, they're going to have pain from malalignment after surgery, which I see all the time from other surgeons' surgeries. And number two, they're going to have a rapid progression of what's called adjacent segment disease, where they're going to end up having problems at the next disc because the alignment was so bad at the disc that they fixed, because they didn't fix it, that it puts strain and stress on the disc above or below. Now, most spine surgeons don't know about this. They know adjacent segment disease occurs. They don't know why. And everyone thinks it's because you have a fusion. That's why you get adjacent segment disease, but that's not the truth. The truth is you get adjacent segment disease because the fusion wasn't done right. And most importantly, the fusion not being done right, I mean that the alignment was not corrected at the segment that was fused. It was not put back into lordosis. And adjacent segment disease is a huge problem in spine surgery. It literally 20% on average of patients that have spinal fusions get adjacent segment disease. And it's 100% preventable. Because now it's on, but it's okay. I still love you, Monica. You found me a nice x-ray machine for $35,000. And, you know, Monica can do no wrong for about 7.3 months at Deuk Spine. After 7.3 months, all bets are off. You better watch your back. All right. So getting back to my point, it's all about alignment, folks, all about alignment. You want to preserve or restore natural alignment of the spine. It is so undervalued by spine surgeons. Now, there are spine surgeons that understand it, more and more so now than ever before. We're understanding just how important alignment is. And so you're seeing surgeons talking about the alignment of the lumbar spine, but also cervical and thoracic are just as important. These are all herniations coming out. And notice we haven't put a metal cage in, we haven't put fusion, we haven't done anything to fuse this spine, and we're not going to. This is the herniation down here as well. There's a little crack right there. Yeah. These are some bone spurs that I'm getting rid of. They're a golden color, particularly on the left there. And that's the end plate of C6. This is herniation here. I got to get rid of that. Now the herniation is going to start like blending over with the what do you call it? The ligament, okay? The posterior longitudinal ligament. So I've got to address whatever part of the ligament I need to in order to remove the herniation. But we are at the back of C5-6, and I'm moving to the patient's right ever so gradually, trying to get all the herniation out. Do we have any more questions?
Not currently.
This is the annular tear right here, by the way. The base of it, right where it attaches to the bone. And it's been disrupted, obviously, by trauma, some kind of trauma that this patient must have had. And it's tried to heal, but ineffectively, because these herniation fragments have been sitting in there blocking the healing. And that's what causes symptomatic disc herniations, is chronic inflammation as the body tries to heal the injury. We have a caller for him. All right, what am I getting here? We have enough irrigation, correct? It almost looks like we're running out of irrigation. Okay? Yeah, that's fine. This is all scarred right here. This is all scar tissue. right there. It's getting calcified. What other questions, Sean? So you're looking at the back of the disc. You're looking at the back of the vertebral bodies. We're sitting inside the disc space right now with this tube, and we're kind of looking over to the right foramen, his right foramen, and this is all shredded annulus fibrosis that needs to be debrided. That's one of the biggest parts of the Deuk laser disc repair surgery, is debridement of the annulus fibrosis, right where the tear is. If you don't clean that annulus fibrosis up, it won't heal. So I need to get rid of this herniation material that's sitting inside the annulus, keeping it from healing. But we got about 8 minutes left here. And then we're gonna, I didn't tell you all, but we're doing 2 surgeries here. We're gonna start with the neck and fix this herniated disc. And then we're going to go to his hand. He has what's called carpal tunnel syndrome as well. And we're gonna have to break down the drapes, and we're going to have to reposition the bed, and then we're going to have to redrape him for a carpal tunnel release. So we're going to broadcast the carpal tunnel release. That's the nerve in the palm that I'm going to be decompressing. And that may surprise you that I do carpal tunnel releases, but I'm a neurosurgeon first and foremost. And the carpal tunnel surgery is something neurosurgeons do quite often as part of our repertoire of treatments. After all, it is a nerve, right? So who better to fix a nerve than a neurosurgeon? So the typical complaints of carpal tunnel are usually numbness in the fingers, the thumb and the pointer finger and the middle finger, numbness, tingling. It usually is worse at night, and the patient will complain about waking up, shaking their hand. And we, a lot of times, will splint the patient, but splinting rarely works, in my opinion. And besides, you don't want to wear wrist sprints the rest of your life. It's really not conducive to being independent. So who wants to wear wrist splints their whole life? It's ridiculous. Now, it's really easy to fix the median nerve compression, but so many surgeons don't know how to do it properly. And Dr. Santiago has done a few of them with me over the years. But there's a right way to do it, and if you do it the right way, you will you'll be able to fix the patient's symptoms quite safely and easily. All right, so I'm just about done here. I'm just trying to get a little bit more lateral and onto that right side. Now, people always wonder, all right, when you're done, is the herniation, is the disc going to be normal? And the answer is no. The disc is never going to look normal again. That's impossible. Only God can make your disc normal. We can only fix what is causing symptoms. And I've never seen a herniation that I've fixed where the disc looks perfectly normal, so don't expect it to. But the idea is to get rid of the symptoms caused by the herniation. All right. So his shoulder here is kind of blocking me from getting a little bit more to the side. But that said, I think we're good. This may be another herniation, and it is. Let me get that out. remember, I'm working through a metal tube. And so that tube has a limited view through the end of it. And I have to move it around to see everything because you can't see everything just through. Can't seem to grab it. Let's see if it's just dancing around my pituitary. Making fun of me, it is. Let's see if I can pulse wave it out. So it's a big one. It's just sitting there laughing at me. As you all know, though, she who laughs last laughs the hardest, right? Huh?
It has to come out.
Well, we're going to get it out. I'm not going to give up on it. But we need to be as resourceful as possible. All right. The last few fragments. We're never going to get 100%, so don't expect to. But you try to get as close to it as you can. So I'm pulling back a little bit on the tube, and I'm letting a few of the fragments that are now sitting there waiting to come out. In the future, I'm letting them present themselves to me.
We have a question.
Yep.
One of our viewers is wondering, will this patient need to wear a neck brace for an extended amount of time?
Yeah, great question. So do patients who have disc surgery like this, do they need to wear a neck brace for an extended period of time? The answer is yes, 6 weeks. That is the period of time. So if you consider that extended, then yes. I don't consider 6 weeks to be extended. I'll tell you about a patient I once treated. She had a story that shocked me. She was from France, and she had an auto accident in France. And she had a herniated disc, and rather than fixing it, this was a few years ago, and I'm not trying to say anything bad about France, trust me, but instead of fixing the herniated disc, they put her in a collar and made her lay in bed for a year, which we could have fixed that herniated disc in literally 1 hour, and then she would have been out of the hospital and home and back to work and normal with an ACDF surgery, anterior cervical discectomy and fusion, or even the laser surgery for that matter. But the doctors at the hospital put her in a collar for a year and put her on bed rest for a year. So I would call that an extended period of time. I wouldn't call 6 weeks an extended period of time. So I'm not sure what your definition of an extended period of time is, but it's maybe different than mine. All right, another herniation. That thing is a monster. So this disc, yeah, it's fine. I can tell you right now, this disc has been badly damaged, and I can't even grab it, it's so big. I can feel it rolling around back there, the herniation, but I can't get it out. So let's see, I'm gonna have to break it up a little bit, loosen it up, wiggle it around, see if I can get it out. See it moving? See it just sliding against the bone? I'm gonna cut it in half. Oh, look at these things. They're giant. These are big pieces of herniation, so big they're not even fitting out of the tube. I'm having to cut them in half with the laser, which is fine, you know. It's just everybody's herniation's a little bit different, you know. They're not all the same, unfortunately, and I wish they were easy. This is easy compared to a fusion, for the patient at least. But herniations don't come out in one piece. They always come out as multiple fragments. And that's what we're seeing here. It's just no different. But everything's going well. Our patient is stable. And for those of you that caught it earlier, this is somebody near and dear to me that I'm operating on. And I have no problem operating on my family members because I want them to get the very best. Unfortunately, most spine surgeons don't do the very best surgery. There's such a massive discrepancy in their training and their experience and their ability that if most spine surgeons, I wouldn't trust most spine surgeons to operate on me or my family. How do you feel about that, Dr. Santiago? Would you agree?
The same way.
Yeah. You've seen enough.
I have seen a lot.
Yeah, and it's horrible. And the worst thing about it is a lot of spine surgeons just don't care. Or they don't think there's a better way to do it. They don't believe there's a better way to do it. So they think, once in a while the patient will die. That's just part of surgery. That's crazy to me. Why should a patient die once in a while? It's unacceptable. I think it's unacceptable. So it just depends on your standard. And the problem is a lot of spine surgeons have very low standards because that's what they were trained to do. That's how they were trained to do it. And I'm just trying to, this show is about educating people about the truth. And so we talk about difficult topics that people don't want to hear maybe. But it's the reality of 2020, 2021, is spine surgery is not done the same by every spine surgeon. We're not a car. You can't buy a Honda Civic here in California versus Florida and it's the same exact car because it's manufactured in the same plant in Japan. Okay? Surgeons are not all manufactured the same way. We all are very different, and we're as different as our training, as different as our personalities. You'll never find two spine surgeons identical. So as you're shopping around to get fixed, understand there's a big difference in outcomes, in the results of surgeons depending on their training. All right, we are just about done here. I'm going to take one more look, and that's a little piece of cartilage on the end plate. I don't know that I can get it. There's a piece of herniation there. That was in the foramen coming out. And remember what I told you, you're never going to get all the herniation. Never. So you want to get enough that the patient's symptoms are gone and the patient is happy with the results and their function has been restored. So if they have weakness, you can fix the weakness. If they have numbness, you fix the numbness. Numbness takes time to resolve. It takes a long time. It can take up to 6 months, even a year in some cases. But look at the clarity of the view, folks. You're seeing the back of the disc better than any spine surgeon has ever seen it. Why? There's another fragment of herniation that was sitting on the spinal cord. All right, we got to get that out. You're seeing it with such clarity because we're right inside the disc with our camera. And I'm telling you, I have the best microscope in the world for doing disc surgery. And the view with the microscope is nowhere near as good as it is with the endoscope. So to really have this incredible detailed picture of what's going on at the level of the herniation and the nerves, you have to have an endoscope. And right now in the whole world, Deuk Spine Institute is the only place that does cervical endoscopic surgery. The Koreans, the South Koreans used to do it, but they stopped doing it because they had some very serious complications with people dying and people being paralyzed. And I believe it has to do with the way they did the surgery. They didn't do it right. Okay? And we've developed a technique here at Deuk Spine that is the right way. And I'd be happy to teach the Koreans if they want to come out here. But until then, I'll just keep operating on them myself. All right, any questions from our audience? We're done with the Deuk laser disc repair. We took out a lot of herniations. And we're going to take this tube out now. I was able to debride the annulus tear on both sides of the disc because the discogram showed us that the problem was on both sides, for sure. Okay? We saw the tear on both sides. So his symptoms were primarily in his right arm, which is why I always go on the opposite side of the patient's worst radicular symptoms, and in his case, right arm. So we went on the left side. But I can treat both sides easily. All right, we're going to take everything out. I'm going to apply a little pressure. There's no bleeding. We lost basically 2 drops of blood the whole surgery. And we're going to close this incision. And then we're going to set up for the carpal tunnel release. The carpal tunnel release, if you want to watch, is pretty interesting. I will use loops and a headlight. So Sean, if you want to set up the head rig with the GoPro, that way our audience can watch me do the carpal tunnel. The surgery is very quick if you know what you're doing and you do it right. It literally takes from skin to skin 5 minutes. The actual cutting of the transverse carpal ligament over the median nerve takes about 2 minutes, and then the closing, it takes the rest of the time. So we're going to broadcast that surgery, even though it's not spine surgery, it is nerve surgery. Nerve surgery. And we think it's of value. So we'll be broadcasting the right carpal tunnel release in about 15 minutes. This is the perfect time. Refill your Diet Coke, pop some more popcorn, you know, flip your seat cushion over. And we're going to show you right now the incision, okay, right here. You all see that?
Yes, we can.
You want the light on, or can you see it good?
We can see it.
4 millimeters. Okay, 4 millimeters. We're going to close it, and then we're going to reposition the patient, and I'll be back. So what do you want to do, Sean? You want me to come answer questions, if there are any? So folks, if you have a question, type it up. I'll come answer it, and then we'll come back to the operating room. Okay? And you guys know what to do? Turn the table. You know how to set it up. All right, good. All right, so overall, that went very well. I was very pleased with the results. Thank you, Luis. Thanks, team. You guys did a great job. We need to put the collar on, absolutely. We're going to keep the patient intubated. All right. Somebody's getting a phone call?
All right, everybody, thank you for joining us for that surgery. If you look up on the screen now, we have this patient's MRI report up. You can see it clearly indicates that the level we just did surgery on had a major disc bulge causing stenosis and nerve compression. That is what we just treated with the laser surgery. In about 15 to 20 minutes, we'll go back to the OR to see a carpal tunnel release on the right side. This is the first time we've streamed this surgery. It's a pretty minor procedure, but it shows you the extent of a neurosurgeon's skill outside of spine and brain. In a few minutes, Dr. Deuk will be joining us in the conference room for a post-op Q&A, so if you have any remaining questions, go ahead and type them in the chat now, and we'll go over to the replay now.
All right, folks, Dr. Deuk here, and we've just completed a cervical Deuk laser disc repair. Deuk laser disc repair is a type of surgery. It's just like if you were to have a spinal fusion or artificial disc. It describes a type of surgery that's being done, and most specifically, what's unique about the Deuk laser disc repair, what's really, really unique about it is that it's done to debride the annular tear in the back of the disc. So the annulus is the containment system that wraps around the center of the disc, which is the jelly center, and the annulus holds the jelly in place. The annulus fibrosus is kind of like an onion in that it has layers of connective tissue. And connective tissue is a type of tissue that is not contractile, so it's not muscle. It doesn't transmit nerve impulses like the nervous tissue, like neurons. It's a supportive tissue, and it's the kind of tissue that basically your skin is made up of. Different types of connective tissue, specifically elastin, collagen, but the annulus is mostly collagen. And collagen is very tough when you have layer upon layer upon layer of it. So the annulus is 20 to 25 layers of collagen wrapped around a jelly core. And the purpose of the disc is really as a shock absorber, functionally the purpose of the disc. As I've talked about many times in the past, the embryology of the disc is quite fascinating. The nucleus pulposus material in the center, which is mostly made up of water and high hyaluronic acid, which seems to be a popular thing online now. High hyaluronic acid is basically a carbohydrate long chain that is hydrophilic, and it basically attracts water molecules, and that's because it's ionized. People wonder about my background. I'm a biochemistry major from UC San Diego, one of the best educations in the world at the time for my undergraduate, and then obviously I went to med school after that at USC. So the biochemistry, cell biology, molecular biology background that I've had in undergraduate for my major was very helpful in me understanding tissues and inflammation and histology, which is the natural, normal tissue and function of the body, and then pathology. So long story short, the jelly center of the disc, the nucleus pulposus, used to be the notochord embryologically, and the notochord basically, there's a word called induction. It basically induced the development of all three germ layers in the embryo very early on, the formation of the ectoderm, the mesoderm, and the endoderm, which ultimately became your intestinal system and visceral organs, your skeletal muscular system, and then your cutaneous system or skin. Long story short, not trying to make this complicated, but want to make it interesting. The notochord is probably one of the most important tissues in an embryo. That it's basically it's not really the when a chef is preparing a meal, it would be really your instructions, all right, the recipe, but it also carries out the actual preparation. So it'd be really the chef in the kitchen, right, preparing a meal. So the notochord is like the chef. It's responsible for taking things like vegetables and meats and carbs and things and putting them all together and creating something amazing. So the food itself won't organize itself into something amazing for you to eat. You need a chef that makes it happen. And so the notochord is really the chef. And you know how important chefs are in preparing good meals. So the notochord is here embryologically within the fetus in the first trimester, causing germ cells to develop and differentiate into all of the adult tissues. And when it's done, the notochord becomes the nucleus pulposus. It becomes the center of the disc, something that nobody even thinks about or cares about. Even spine surgeons don't think about it and care about it the way that I do, because I have such a deep respect for it and its function and purpose in life. And so all of this back pain and neck pain and thoracic pain that people get that doesn't come from the facet joints, it comes from the annular tear. And the annular tear itself is not painful. It may hurt for a few minutes. What's painful is that the nucleus pulposus, or jelly, squeezes out into the annular tear and then keeps the annulus from resealing and healing. And it sets up an inflammatory cascade, this nuclear material. It's called a herniation. And any tissue that squeezes out of position that it's normally in into a position that it's not supposed to be through a wall or membrane is called a herniation. And so whether it's your intestines herniating out through your anterior abdominal wall or your inguinal canal, whether it's your intestines herniating out through a surgical incision that was used to do surgery on your belly, whether it's your nucleus pulposus herniating out through the annular tear, it's called a herniation. All right? So herniations are not unique to discs. They actually happen throughout the body whenever you have one tissue moving through another. There just aren't a lot of cases of herniation, okay? Like the stomach, for example, the top of the stomach or fundus can herniate out through the diaphragm, right? And that's also another example of a herniation in the body. The herniations I'm talking about are the nucleus pulposus, or jelly in the center of the disc, herniating out through the annular tear and causing inflammation. So this is the whole basis of the Deuk laser disc repair. This was our discovery and our contribution to medicine. One of them is that the back pain that people have, chronic back pain, chronic neck pain, chronic thoracic pain, pick your section of the spine, it doesn't matter, neck, thoracic, or back, lower back. When you have a herniated disc causing pain, so first of all, herniated discs do cause back pain, which all of my colleagues don't understand except for a few. They don't believe a disc can cause back pain. They don't know that a disc can cause back pain. They don't know that herniated discs cause back pain. As a matter of fact, up until today, most spine surgeons, neurosurgeons are told that back pain is nonspecific. It doesn't have a cause, except if you have a fracture, then it has a cause. It's the fracture. If you have a tumor, then it has a cause. It's the tumor causing a fracture. If you have an infection in your spine and that's painful, then it's the inflammation from the infection that causes pain. But aside from infection, tumors, and fractures, neurosurgeons, orthopedic spine surgeons are all taught that the pain is nonspecific. In other words, they can't figure out where it's coming from. So the first thing we did here at Deuk Spine Institute is we figured out that a lot of back pain and neck pain and thoracic pain comes from herniated discs. It comes from the disc itself, what's herniated. And the herniation doesn't have to be big. It can be very small. It has to be a grade 3 herniation, or 4 or 5. There's no pain that comes from a grade 1 or grade 2. It's always grade 3, 4, or 5. So there are 5 grades of herniation depending on how much of the annulus is torn and how much of the nucleus squeezes through the tear and herniates. And grade 1 and grade 2 herniations, I've never seen them, they never cause pain. But grade 3, 4, and 5 do. I'm not going to go into the different types of herniations, but just understand a grade 3 is a full thickness tear of the annulus fibrosus from in to out, all the way from the inner surface to the outer surface. And that can definitely cause back pain because there's always going to be some nuclear material that's squeezed out through it that's causing inflammation. The next thing that we contributed was that it's the posterior annular tear, not the sides, not the front of the disc. So annular tears in the front of the disc and the sides of the disc don't cause back pain or neck pain, any kind of disc pain. Only annular tears in the back of the disc cause pain. The Deuk laser disc repair surgery targets the annular tear in the back of the disc where the pain is coming from. So if this patient had a front annular tear and a side annular tear and a back annular tear, all three, we would leave the front and side alone. We would cure their pain by just fixing the annular tear posteriorly. We call it posteriorly, means in the back of the disc, okay? You must fix the annular tear in the back of the disc posteriorly if you want to get rid of some patient's pain. So again, this is another discovery that Deuk Spine Institute made that we've published and we've told the world. But again, everyone else is so far behind in this that they don't know any of this stuff. And we do. And so that's why we've been able to cure back and neck pain without doing fusions, without doing artificial discs, because we can identify the exact source of the pain. And I will tell you this, sometimes it's more than one disc. Maybe it's 2 discs that need to be fixed, or 3. So that's another contribution Deuk Spine has made. Most spine surgeons will only fix 1 disc at a time. And that's because, for whatever reason, they just taught or believe or dogma for years that just 1 disc needs to be fixed. The truth is, if you're having pain from 2 discs or 3, you need all 3 fixed. Otherwise, you're still going to have pain. And it's the fact that surgeons only fix 1 disc at a time when the patient needs 2 or 3 fixed. It's that fact that has caused so much confusion about spine surgery. Because people say, oh yeah, we had spine surgery, but it didn't take care of my pain. It didn't take care of your pain because the correct sources of the pain weren't identified or they weren't treated. So that's another contribution from Deuk Spine Institute to the world in treatment and curing of back and neck pain, is that you must find all sources of pain and treat them all. There's not just one source of pain for each patient. And by the way, there's no such thing as non-specific pain. So since we're talking and nobody's asked questions yet, there is a question. I'm going to answer it in a minute. I want to talk about fibromyalgia. I was brought up in my training to believe that fibromyalgia was real and that fibromyalgia was extremely common. And what fibromyalgia is it's a pain that people get in their neck or back that can't be cured because the pain is coming from the muscles and skin. I'm going to tell you that I truly believe fibromyalgia exists, but here's where I differ in my belief, my knowledge, the truth about fibromyalgia. There seems to be this belief that fibromyalgia is very common. It's a common cause of back pain or neck pain. In reality, fibromyalgia is extremely rare. Extremely rare. Let me tell you how rare it is. Every single day that I'm at work, I treat back and neck pain. I treat nothing else but back and neck pain all day long. We see 30 to 50,000 patients a year in visits here at Deuk Spine. 30 to 50,000 patient visits a year. And I've been doing this for 25 years. So in 25 years, with 30 to 50,000 patient visits a year, I've seen 2 cases of fibromyalgia. That's how rare it really is. So then what are all these people with fibromyalgia? Why are they being diagnosed with fibromyalgia if they don't really have it? It's because the doctors don't know what they have. So they just tell the patient they have fibromyalgia because they can't figure out what's wrong. They don't have the tools, they don't have the knowledge, they don't have the experience. That's why if you have back or neck pain, you want to come to a facility like Deuk Spine Institute where we can make the correct diagnosis and we can fix it for you. If you go elsewhere, you're going to get the wrong diagnosis, you're going to get the wrong treatment, and you're still going to be in pain. That's really what this entire broadcast is about. It's about educating the public about the causes of back and neck pain that are completely curable to cure people's pain and get them on with life, okay? You don't have to live with chronic back or neck or thoracic pain anymore. It can be cured, but it can't be cured necessarily where you live and with your doctor. You have to find someone who understands it and can fix it for you. All right, Sean, let's have our question.
So our first question comes from a viewer on YouTube who asks, what are some of the strangest procedures you've done as a neurosurgeon outside of brain and spine?
Great question. So what are some of the strangest procedures you've done as a neurosurgeon outside of brain and spine? Well, by definition, I think strange means that it's something unusual that you don't typically do. And I appreciate that. And so I'm just trying to think back on something I've done that would be out of the ordinary. and unusual. And for me to do that, I honestly have to go back to residency, and I'll tell you one strange procedure I did that was shocking, absolutely shocking. Well, I was on call in the emergency room at Shands Hospital in Gainesville, and this was back in 97, 98. So we're talking about, what, 22, 23 years ago. And we had a patient came in to the emergency room, and his skull and scalp were missing in a large part of his head. They were missing, and there was a huge growth on there instead. It turned out that it was cancer, skin cancer. It's called basal cell carcinoma. The problem was that the guy did not ever seek medical care because he truly believed that God would take care of whatever the problem was. And, you know, of course we all know God helps those who help themselves. And this patient never went to the doctor to get it fixed. So a small little skin cancer that could have been zapped away in 1 minute and fixed, he let it grow for years. And as it grew, this cancer started to eat through his skull, and eventually it ate into his brain. So when he came in that day that I was on call, his brain was exposed, about the size of a teacup. And there were maggots wiggling around in his brain, literally eating his brain. And so, yeah, that's probably the strangest thing I ever saw, but it does relate to the brain. Aside from that, I really never did much else. I've just focused on neurosurgery. I always try to stick to things that I know well. Our next question.
Our next question comes from a viewer on YouTube as well who asks, what percentage of herniation is removed with DLDR?
So the question is, from somebody on YouTube, what percentage of herniation is removed with DLDR? And the answer is we remove 100% of the herniation. Remember, the herniation itself is really, it's the nucleus pulposus, the jelly in the center of the disc that has squeezed out through the tear in the annulus fibrosus, the part of the disc, the wall around the outside. Once the jelly has pushed through the annulus fibrosus tear, and either it's stuck in the annulus tear or it's squeezed out even further into the epidural space, that herniation is pretty easy to remove. You know, you just have to pull it out or laser it out like I do. But we can get rid of 100% of the herniation. Yeah, so that's what we do. We probably get rid of about 98% of it on average. And, you know, the herniation itself represents about 5% of the total disc. So, you know, some herniations are bigger than others, and certainly you can get up to 10%, maybe even 15% of the total disc volume. But I would say in all my years of experience, the average volume of disc herniation that most patients have is 5% of their disc volume. So it doesn't take much of the disc to squeeze out to cause symptoms. It's in a very high real estate, high priority place. It's right near the nerves.
And our last question, how often do you perform ALIF surgery? And is it a very common operation?
Okay, our last question comes from what, YouTube or Facebook or Periscope? Comes from YouTube. One of our viewers is asking, Dr. Deuk, you're a spine surgeon. You've been doing this 25 years. How often do you perform ALIF surgery? And is it a very common operation? That's their question. So for those of you who don't know what ALIF is, it stands for anterior lumbar interbody fusion. ALIF surgery is an older surgery that is still in use in some places to fix problems with the lumbar spine. So this is for lower back. This is not for neck, not for thoracic. This is lumbar. So anterior lumbar interbody fusion. And basically what the surgeon's doing is cutting the belly of the patient and then moving all the chitlins aside and exposing the front of the spine, cleaning out the disc from the front, and then putting a cage or a bone graft in through the front and maybe a metal plate to hold it together, drilled into the spine. How often do I perform that surgery? The answer is I don't perform it anymore. I used to perform it many years ago in the beginning of my training because many of my attendings were orthopedic surgeons, and that's how orthopedic surgeons like to do lumbar fusions, is through the front. Neurosurgeons, we're able to go through the front or the back or the side. And the truth is going through the front is far more dangerous and risky of complications. So I don't do ALIF surgery because the complication rate is too high, in my opinion. So even if I did ALIFs, which I do very good ALIFs, and I've never had a complication with an ALIF, I would never do ALIFs because from my standpoint, it's a much more dangerous surgery, and even though I've never had a complication from any of my ALIFs, the chance of complication is dramatically higher going through an ALIF procedure than through a T-lift procedure through the back. Okay? Now, let's say you have a surgeon living near you and working near you who he does 100 ALIFs a year and he's never done a T-lift. Okay? If you go to that surgeon and say, do a T-lift on me, he'll probably kill you because he or she's never done it before. And so it's going to be very dangerous for the patient to have a procedure that's never been done before by their surgeon. So what I'm getting at is it's very important that when you pick your surgeon and your procedure, you pick a procedure the surgeon is very comfortable doing and has a very low complication rate doing it and a very high success rate. So for example, you may have a surgeon who's never done T-lift who's doing A-lifts, and he does 100 A-lifts a year, and he has a complication rate of 10%, okay? And it would be better for you to go to that 10% complication rate. That means you have a 1 in 10 chance of having a complication rather than going to, say, a T-lift surgeon that has a complication rate of 30%, right? Because a T-lift surgeon going through the back has a higher complication rate of 30% than the A-lift surgeon with 10%. See, patients really need to understand ultimately a few things that are very important when it comes to spine surgery. The first is, what's the chance that you're going to get rid of my symptoms? What's the chance you're going to cure my pain? Okay, I want the highest chance. I want 100%. That's my goal. I want a 100% chance you're going to cure my pain. Of course, most surgeons can't deliver that. Okay, they can only give you 50%, maybe 20%, but you want the surgeon that's going to give you the highest chance of successfully eliminating your pain. At Deuk Spine Institute, we're at 98% on average. That's average, and that's not our number. That's the number patients give us when they come back and see us. We ask them, what percentage of your pain did we get rid of? They give us a number, we write it down. Then we have a research assistant go through all the records and charts and take all those numbers and average them, and our average is 98% elimination of neck pain, back pain with the treatments here at Deuk Spine Institute. The second thing you're going to want to know as a patient is, okay, you can fix my pain, I'm happy about that, but what's the chance you're going to have a complication from your surgery? What's the chance I could bleed to death, or I could puncture my organs, and I can have, have to have bowel surgery, to repair my bowels. And of course, bowel surgery leads to more bowel surgery because you get scar tissue in your belly, and then you're going to have more surgery later. So what's the chance I'm going to get a complication from your surgery? Spinal fluid leak, bleeding, some scar tissue, some kind of instability, some damage. And unfortunately, in spine surgery, that's very high. With most surgeons, it's very high. You're looking at 10 to 50% depending on where you go. At Deuk Spine Institute, we have a 0% complication rate with the laser surgeries you just watched. Okay, 0. I've never had a complication in 1,200 cases. 15 years of doing the endoscopic cervical, thoracic, and lumbar, we've never had a complication. Not one. So from a safety standpoint, this procedure, the Deuk laser disc repair, is the lowest complication rate in the world for any spine surgery, because there's no other spine surgery in the world that has a complication rate of 0. So why is it so unique that we have a complication rate of 0? Well, you have one surgeon doing the procedure, me, the guy who invented it and pioneered it. And I'm a very good surgeon, technically. And so you have a surgeon who normally has almost no complications because of technique and understanding of anatomy and caring and about the patient and outcomes. And then you add on top of that a very safe endoscopic surgery. Then you have basically a procedure now that's being done that has a complication rate of 0. Imagine if all spine surgery had a complication rate of 0. More people would be getting fixed. The third thing you're going to want is you're going to want to know how long is it going to take for me to recover. And so success, lack of complications, and quick recovery are the things, the golden triangle. That's what everybody wants for spine surgery. So that's really your main focus when you're trying to find a surgeon to fix your spine with surgery. You want, what's the chance of success? I want it to be very high. What's the chance of complications? I want it to be extremely low, if not 0. And what's my recovery going to be? When do I go back to work? When do I go back to school? When do I go back to playing sports or going to the gym or golfing? So with those 3 things in mind, there is no surgery in the world that has better results for any of those 3 than the Deuk laser disc repair that we just did. Okay? Now I got to go back and do surgery, so we're going to do the carpal tunnel right